Hello there, my name is Dr. Christian Ratzloff. I am a second year internal medicine resident at UAMS Northwest. The case I am presenting today is a case of infectious aortitis due to Salmonella, and this patient underwent endovascular graft repair. So this is the case of an 84-year-old male that presented to the ED with diffuse abdominal pain, flank pain, and fevers. In the emergency department, CT abdomen and pelvis showed periaortic inflammatory changes involving the infrarenal abdominal aorta. Patient notably had a recent history of E. coli UTI treated with a course of ciprofloxacin. Upon admission, the differential for aortitis findings on the CT abdomen and pelvis were very broad, including many autoimmune and infectious etiologies. We initially placed consults to infectious disease and rheumatology. Chest X-ray and UA were negative for abnormalities. ESR was elevated at 36 and CRP at 116. Rheumatology recommended holding off on empiric antibiotics, and infectious workup was started. The next day, infectious disease empirically started Rosefin based on patient's history and high suspicion for infection. Day 1 into admission, blood cultures returned positive for Salmonella species. Urine culture was negative. Due to patient having a pacemaker, there was concern for infection of the device. Patient did have a TEE during their hospital stay, but that was negative for vegetations. The Salmonella that was grown on the blood cultures was sensitive to fluoroquinolones. The patient remained afebrile for the last 24 hours of their stay in the hospital and was discharged on a 6-week course of Levaquin with follow-up scheduled at an infectious disease clinic. They had a repeat CT abdomen pelvis 2 months later, which showed improved inflammatory changes in the periaortic region of the retroperitoneum with ectasia of the infrarenal abdominal aorta with a posterior expansion of contrast beyond the atherosclerotic disease. And due to these persistence of findings on the CT and concern for aortic wall injury or laxity, it was suggested by infectious disease that the patient follow up with a thoracic surgeon who then recommended AFX and endovascular graft placement to cover what was described as a penetrating aortic ulcer with aortitis. And kind of in conclusion, this case highlights how aortitis can present with nonspecific clinical symptoms requiring a speedy diagnostic workup. Like I had mentioned earlier, the differential for aortitis is very broad, and this case required interdisciplinary teamwork and shared decision-making with the patient. Unfortunately, we were never able to actually elucidate the source of Salmonella bacteremia, which happens to be the case in about 50% of these cases of infectious aortitis. In most cases, it's linked to a previous gastrointestinal illness. We try to really dig deep in patient history to try and see if that is the case for all of these patients, but in ours, it doesn't seem like that was the case. But this case really utilized the expertise of multiple specialists and physicians. We had input from emergency medicine, the hospitalists, infectious disease, rheumatology, and cardiothoracic surgery physicians. In this case, the patient was fortunate enough to have swift diagnosis before their aortic findings progressed to aortic aneurysm or even aortic dissection. Thank you for taking the time to listen to this case presentation. I hope that you found it as interesting as I did. Thanks.